How's it going, guys? It is 2:09 a.m., 31st of March, Friday here in Japan. Past the little question for internal medicine surgery TCK for studying for step one. I mean, this is fair game. It's an important diagnosis you should be aware of. Before we get started, please subscribe to my channel. Really appreciate it. Give it a like. Really appreciate it. Find me on Instagram, mehlman_medical, mehlman_medical. Links down below. Find me on Telegram. Links to the Telegram group and channel down below. Let's start the clip. 77-year-old man. He's brought in to emergency by his wife 2 hours after onset of severe abdo pain. He has no past medical history. Temperature is 100 Fahrenheit. Physical exam shows mild tenderness, palpation of the abdomen. There's no involuntary guarding, which the following is the next best step in management. We have this ECG here. Okay, so this is showing us atrial fibrillation. This is a pass level ECG. Okay, I made it pretty big. I mean, this is pretty much the easiest AFib ECG I could find. You can see that there's an irregular distance between the QRS complexes. Okay, there's a regularly irregular. There are different distances from each other, no pattern, and there's absent P waves. Those are the two things you're looking for in ECG with atrial fibrillation. And this dude has severe abdo pain. So what's going on here? So let's just hop to the answers here. Choice A, CT the abdomen, wrong fucking answer. I mean, look, we could use this for a myriad of things. I'd say highest yield would be pancreatic cancer, long discussion, increased ALP, direct bilirubin, normal pancreatic enzymes, smoker, classically weight loss, diverticulitis, extremely important, don't scope an acute diverticulitis, focal nodular hyperplasia, show lesion, central scar of the liver, also lengthy discussion. Point is, wrong fucking answer. Choice B, echocardiography, wrong answer, although this is important to do in this patient, just not immediately, okay? So patients who have atrial fibrillation, you're gonna do a standard ECG first. Now, if an ECG shows sinus rhythm, no abnormalities, but we suspect AFib, let's say patient has normal blood pressure, has a stroke, TIA, retinal artery occlusion, we know it's not gonna be carotid stenosis. So we say, sounds like AF, but the ECG is normal. Probably paroxysmal AF, comes and goes. That's how AF normally is. So you do a 24-hour Holter monitor, okay, which will pick up the AF when the guy goes home and has dinner, okay? So when you pick up the atrial fibrillation via 24-hour Holter monitor, 24-hour ambulatory ECG monitor, then the next best step after that is you do an echo to visualize left atrial mural thrombus, okay? So he will need an echo in the setting of AF. It's wrong fucking answer in this case. Holter monitor, also wrong fucking answer because we already know we have AF. As I just fucking said, we're only going to do a Holter monitor if the ECG is normal, but we strongly suspect AF. Choice D, mesenteric angiography, correct answer. This is going to be acute mesenteric ischemia, where you have a left atrial mural thrombus that's launched off to the SMA or IMA. It causes colloquially pain out of proportion to the physical exam. So this dude has excruciating abdo pain. Holy shit. But then you do the physical exam and it's nothing dramatic. Okay, I mean, I've seen this type of presentation on nbme exam. They say mild tenderness, palpation of the abdomen. There's no involuntary guarding. Okay, so involuntary guarding is when he has a rigid board-like abdomen. You're going to see that. That's due to parietal inflammation of the parietal peritoneal inflammation. You're going to see that with appendicitis. You're also going to see that with ruptured duodenal ulcer. Okay, the latter, you're going to do air, look for air under the diaphragm, do chest and abdominal x-rays. But this is acute mesenteric ischemia, okay? And so can occur in the setting of atrial fibrillation. You're going to do mesenteric angiography to diagnose exceedingly high yield. And I've also seen laparotomy as an answer. As a next best step after angiography shows the diagnosis. I have not seen endarterectomy as an answer. It's a long discussion. You can also defibrillate a patient and have a clot launch off. That is a vignette in one of the nbme exams. You can also have chronic mesenteric ischemia, which is completely different. It's a patient who has atherosclerosis, presents like a duodenal ulcer, abdominal pain 1 to 2 hours after eating meals. You say, sounds like H. pylori, duodenal ulcer, but it's not. It's going to be a patient who has a big cardiovascular disease history, essentially angina of the bowel, okay, atherosclerosis. And then they're going to get a ruptured plaque, literally, of the SMA or IMA. They get acute on chronic, acute mesenteric ischemia on chronic mesenteric ischemia. That's the other vignette. So Real quick, serum troponin's wrong fucking answer. It's clearly not an MI here. Students not really sure. They're just going to choose this answer. Actually, not even a high yield answer on USMLE. Okay, clearly, if someone has an MI, you give dual antiplatelet therapy. You're going to give aspirin first, then clopidogrel. You will get their troponins. Yes, I have seen this on 2CK. You'll also do this for suspected myocardial contusion. If you have an MVA, motor vehicle accident, and there's bruising or pain over the sternum, you want to monitor for potential arrhythmia and get serum troponins. Wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. I appreciate your time. That's it.